So, thanks, Pranay. This is my second talk for today. That is on Venous ECMO. This is a very important talk because the basic mechanisms for us to do ECMO is either venous or arterial as per the need. I will deal with venous. The objectives are looking at the indications, statistics, advantages and disadvantages, monitoring and the management of ECMO. Very briefly, I will touch upon with weaning and complications. Humans are blessed with unique mechanism by the Almighty. As you can see here, the functioning air exchange unit or the gas exchange unit alveolus. This slide I took from ResearchGate. It shows beautifully the structure of healthy alveolus to the right side and diseased alveolus to the left side of the slide here. You can see the healthy alveolus is empty, allowing gas exchange here. There are very few alveolar macrophages with the type 2 surfactant cells along the border and lining in epithelial basement membrane outside, and inside is the lining here with some of these type 2 surfactant cells. So from there, we understand this layer is smeared with the surfactant, so that keeps the uh, is the function of the alveolus better by avoiding the collapse of the alveolus. Then slightly looking at the right side where how the diseased alveolus looks like, it has so much of fluid inside in the alveolar cavity and the exudate going over there with leukotrienes, oxidants, proteases, tumor necrosis factor, and all these kinds of neutrophils, macrophages, they tend to get into the alveolar lumen, into the interior of the alveolar space. So you can also see the alveolar wall is lined with hyaline membrane now, unlike the previous surfactant layer. And the space outside the alveolus, which is a very thin space before the interstitial space, that has widened significantly here. Macrophages coming in once again, increasing edema. uh, so the gas exchange between capillaries and the alveolar surface becomes very difficult under these circumstances. So now it should be easy for you to understand why it takes so long for a diseased alveolus to get back to normalcy during the process of repair. We are fortunate because this is not a homogeneous mechanism, this is heterogeneous mechanism. What I mean by that is some of the alveoli, they are dead and some are going through the process of necrosis, and some are healthy alveoli over there, some are in the intermediary period, and that's the reason we are surviving. So when only nearly 30% of the cells are alveoli are affected, we can treat them without need for oxygen with antibiotic therapy, cyst physio, etc. But when the percentage of the alveoli getting infected are increasing more and more, then further need for mechanical circulatory support will come, and towards the end, of course, is ECMO. So we know venous ECMO, it is a supportive mechanism, it is not a cure. We know nature is great and it heals most of the things given time. Our principle is do no harm and support during the repair process. The understanding principle is simple. Collect blood from the biggest venous reservoir and take it through oxygenator for gas exchange at the right temperature. And once the uh, oxygen is delivered to the RBC, then return the blood back to the uh, patient. So the gas exchange process is maintained till the lungs take over the function. This is a circuit diagram of how it looks like. You can see one of the ECMO cannula, the venous cannula is coming off the baby here. with side ports called as pigtails, and from there it's going to the console. The console drives the blood forward through the oxygenator at the right temperature. The oxygenated blood goes back to the patient again. So this is the cycle. We just learnt about our first case of ECMO in 1975. That was Esperanza. I like this slide very much. It is a beautiful slide showing us and explaining us the whole process of ECMO. We do ECMO when there is hypoxia or hypercarbia, and the mechanisms how we can do that is AV, arteriovenous, veno-arterial, and VV ECMO. So the blood is taken from the reservoir and it flows there. Around that is, and it is anticoagulated, and there is a membrane oxygenator with the gas flowing in that. Gas exchange takes place, and the blood is delivered either to the lungs or to the heart. We remove dark blood from IVC or SVC or both. Remove the bright blood is returned to the right atrium. It mixes with rest of the venous blood and goes to the right ventricle. Oxygen carbon dioxide content in the arterial blood is a mixture of returned circuit blood, venous blood that bypasses the circuit, and any gas exchange happening in the recovering lungs also. So it is complex, but still, this oxygenated blood which goes back to the patient as a combination of this, but it is not 100% oxygenated. There is some venous blood which is mixing with that also. It doesn't matter. Carbon dioxide clearance is relatively easy and ECMO. Oxygen delivery is the key and can be troublesome. Gas diversion for the venous blood is 75% or greater. Needs large drainage cannula, and if lungs are non-functional, saturations will be in the 80s. So we have to mind that. Monitor the surrogates of tissue hypoxia. One of the diagram showing you a WMN cannula. Here from the venous sides, blood will be drawn from the inferior vena cava below and superior vena cava upstairs. From that, the blood will be drawn into venous circulation into the venous limb of the ECMO cannula. From there, it goes to the membrane oxygenator. Whereas the returning blood, the oxygenated blood will come to the right atrium, uh, and the holes are put in such a way that blood faces the tricuspid valve and it goes through the tricuspid valve. So there's some amount of recirculation happening. It is tolerable. We can minimize it. We cannot completely avoid it. Indications are basically reversible respiratory conditions where the heart is not under heavy stress. Though we feel and we say like the function of the heart, function of the lungs, it is never like that. It is in a constant dynamic circulation. So blood from the heart goes to the lungs, blood from the lungs goes to the heart like that. It is in a continuous circulation. Uh, Common and adult pediatric indications are commonly the pneumonias, ARDS picture, acute reversible respiratory failure, status asthmaticus, one of the very good indications, because once there is hypercarbia in asthma, it doesn't give us a lot of time for that. If it is difficult to control asthma, patients may not respond very well to the bronchodilators initiated. So ECMO is the mechanism of choice at this time for them to go on to, and with the 100% success rate while an ECMO, as it is a short-term therapy just for days of couple of days till the lungs start to get better again. Pulmonary hemorrhage can be a complication. Perioperative support for the airway surgery and severe air leaks, burns, etc. These are all indications for ECMO. Burns means respiratory burns. not amenable to ECMO. When these conditions are there and it is evident, then we don't want to place the patients on ECMO. Sometimes, as it is a gray area, we may not know initially if the patient has got any of these conditions in those cases. Some of these conditions are such as congenital pulmonary malformations, lymphangiectasia, congenital surfactant deficiencies, and alveolo-capillary dysplasia. When these conditions are there, immediately soon after birth, they are not diagnosable, but they are all present with secondary pulmonary hypertension. So we tend to put them on ECMO as well. But it is satisfying because a lot of these patients can be saved by conventional measures also. Some of these patients, not a lot, sorry, some of these patients can be saved, and for some of them there is no answer, and unfortunately we have to lose them. Those are the exceptional cases of surfactant protein B deficiency and alveolo-capillary dysplasia. The treatment for them is lung transplantation, but neonatal lung transplantation is a difficult choice even in the Western world. In the neonatal period, ECMO contraindications are age less than 34 weeks. You can imagine, as the possibility of intraventricular hemorrhage is much more below 32 weeks gestation. So people have put it as less than 34 weeks gestation, not a candidate for ECMO. And we tend to see a lot of negative effects in those children. Similarly, weight of less than 2 kilos, these are relative criteria, not absolute criteria. There are cases with 1.6 kilo also, we put them on ECMO. They were grown up babies, at least couple of months old, and uh, these things can happen as well. These are relative contraindications. Ventilation of more than 10 days as a high pressure ventilation, that's all it matters. It is not the total duration of ventilation, but it is the duration of high pressure ventilation that matters. Intracranial hemorrhage, intraventricular hemorrhage of more than grade 2. If it is a grade 3 hemorrhage or grade 4 hemorrhage, then we don't want to put the patients on ECMO, because for going on to ECMO, they have to be on heparinization as well, and your heparinization is likely to make intracerebral bleed worse. So we don't intend to continue the patients on ECMO if there are other ways of treating them. Disease with the poor outcome and limited heparinization. Pregnancy also can be helped by ECMO a lot. Pregnancy complications at the time of delivery, the eclampsias, pre-eclampsias, severe ARDH secondary to H1N1 in pregnancy, even in COVID patients also, massive obstructive obstetric hemorrhage can be helped with ECMO. Severe sepsis, just like anybody else also, severe sepsis is another one which can be helped with ECMO. Sorry. Modes of ECMO are venous ECMO or arterial ECMO. So I'm dealing with only venous ECMO here. So the blood is drained from the right atrium, either jugular vein or the femoral vein, and returned to the same cannula into the right atrium from uh, or second cannula through the femoral or jugular vein also. Sorry, thirsty. Arterial ECMO, I'm not going into depth about it, but just mentioning about it here because in neonatal cases, when cannula cannot be passed into the venous circulation, such if it is not big enough, then in those cases, blood is drained from the right atrium, and still we will be returning the blood through the aortic arch by embracing a technique of veno arterial ECMO. even for respiratory reasons also. So that is the only reason I mentioned veno arterial ECMO over here. The features of VV ECMO are percutaneous cannulation is possible, carotid artery remains intact and for us do no need to touch it. Minor cardiac support only. We go by this with the inotropic score. Coronary artery blood is oxygenated. Monitoring via arterial saturations is possible and it is suitable only for the respiratory disease. The referral criteria are high peak inspiratory pressure, high PEEP, and high FiO2. But here these high indicators are taken when only during the duration when high support is needed for the patient. By this, what I mean is if the patient has been in ECMO for 20 days and the settings have been very high for the past 2 days or 3 days, you consider these 2 or 3 days as the indication for ECMO referral criteria rather than the entire period of 20 days as the ECMO referral criteria. It depends on the disease, speed of onset, and the stage also. Individual assessment remains a priority with this. ECMO contraindications in any age group are ventilation of more than 7 days, intracranial bleed, irreversible disease, disease with poor outcome, and limited heparinization. Some of the pictures showing you cannulae. This is a child with a single cannula in the right atrium here. Actually, as you can see, multiple drainage cannulas there. In this baby, barotrauma has happened secondary to um, high pressure ventilation or some other process with multiple pneumothoraces, and that's why baby went on to ECMO. Here also, the tip of the cannula in the right atrium here, and you can appreciate the lungs so densely white out. For the neonates, there is a reliable criteria to decide when they need ECMO, that is oxygenation index. Oxygenation index is nothing but mean airway pressure times FiO2 divided by PaO2 in millimeters of mercury. That is more than 40 for more than 4 hours. It correlates with the 80% mortality. So these patients are definitely indicators for going on to ECMO. But the physician can guess the speed of or rapidity of deterioration of the patient also, and that has a lot to tell you about who needs ECMO and who doesn't need ECMO. Murray score is a useful criteria in case of adolescents and adults. Murray score has certain criteria such as PaO2 by FiO2, chest X-ray, how many uh, quadrants in the chest X-ray are involved, PEEP, certain numbers as you can see there, less than 5, 6 to 8, 9 to 11, etc. Compliance from the ventilator, that also you can measure with this. So when you calculate the total score as per the score given for a patient, then you divide it by 4, and if that number is more than 3, then those are ECMO candidates. This is the importance of Murray score, which is a reliable parameter. Other ways to measure failure are arterial partial pressure of less than 50 millimeters of mercury for 4 hours or more, cardiovascular instability, difficulty to improve, and failure to improve, pathophysiology of the disease and physician's viewpoint. These are the other things which are difficult to um, mm, control, and they become indications for going on to ECMO. The cannulation for VV and VA are appropriate size WMN cannula if is available. The tip of the cannula in the lower third of the right atrium is essential, and arterial side holes are facing tricuspid valve. So they by the oxygenated blood returns to the um, tricuspid valve through the right atrium, right ventricle, and goes through the lungs again. More lines may be needed in a hybrid cannulation. You will read about hybrid cannulation uh, in one of these classes. Common carotid or tip of the cannula as orifice of the innominate artery in the veno-arterial ECMO. Because this is in case of neonatal ECMO, because of the small size, they do not admit anything less than 13 French W-man cannula. And a newborn baby with a weight of 3 kilos approximately can only admit 12 French cannula, not 13 French cannula. For a baby to admit 13 French cannula, its weight has to be more than 3.5 kilo. So, when a W-man cannula is not available, either because of cannula availability problems or because of cannula accessibility problems, we tend to put them on the veno arterial ECMO here, even for respiratory reasons. This is one of the W-man cannula. Same cannula, W-man cannula, showing you two here. One is the red, which is arterial, and blue is the venous here, and there are side holes here you can see. Avalon cannula developed by Schwiesberger. This has been in use for the past 4 decades and very useful cannula. Further improvements on this are taking place. Again, how it looks like when it is in situ here, it is in the right atrium, filled with the blood going to the right ventricle as such, SVC on the top and IVC on the bottom here. See again endotracheal tube and the cannulation. This is veno arterial ECMO cannulation picture. On the left side, you are seeing on the right side you are seeing uh, here it is the venous cannula here, and left side is the arterial cannula there. So here is a single lumen double lumen cannula or double lumen single cannula in place in the right atrium via internal jugular vein. The insertion of the cannula is done by either intensivist or surgeons. Um, the least available size is 13 French only. Here is a baby on two different cannulas, one on the veno arterial ECMO and one on veno venous ECMO. This is the W-man cannula to the left side and two separate cannulas to the right side you can see. Similarly, in an adult, venous drainage is collected through the inferior vena cava from the venous cannula here. Okay, another X-ray here with the double lumen cannula in situ, and here how a single lumen cannula looks like. VA ECMO advantages and disadvantages are: the advantages are pulmonary vasodilatation is possible, myocardial oxygenation, it maintains pulmonary blood flow and minimally invasive also. The disadvantage is slower stabilization, circulatory support is not available, recirculation is possible. When baby goes on to ECMO or an adult goes on to ECMO, we tend to reduce their ventilator settings to the basic minimum and try to work with ECMO. This is because we have been battering uh, mm, these lungs with the high pressure so far. That's why we want to bring it down to low pressure settings And the standard settings advised are 20 over 10 millimeters of mercury as with the pressures, PB rate of 10 per minute, and FiO2 brought down to very minimal 21% to 30%. This is called rest ventilator settings. All the patients may not be able to go to the rest ventilatory settings immediately, but within a short span of time, they should be able to go on to rest ventilator settings. And it is extremely vital to put the patients on rest ventilator settings. Otherwise, there is no point in going on to ECMO because this is the period when lungs tend to heal. VV ECMO management is in the whole world more or less it's the same mechanism. With the hebronization, we'd like to keep activated clotting time up to 160 to 80 seconds. Chest physiotherapy, prone position, maintain the fluid balance. Dry fluid balance is very important as well. If someone is obese, certainly they need to lose their weight. uh, Rest ventilatory settings are important. Awake ECMO, early enteral nutrition, and infection control. These are the best measures. VV ECMO, there are complications, both patient related and staff related complications also. They are like any other specialty, but here um, patient related complications are much more important here. Air embolism, pulmonary failure, like circuit related complications also happen, but patient related complications are much more common. So, the recirculation, I need to tell you a word about recirculation. Recirculation is the fraction of the blood which is purified by oxygenator, returns to the patient and goes back to the venous circulation once again without going to the um, tissues. So here is the wastage, significant wastage, because this blood is already oxygenated. There is no need for it to be reoxygenated as such. So this is wastage. This is called as recirculation. We can mean there are certain factors which lead to increased recirculation and certain factors which help in reducing the recirculation. Here you can see very clearly how the recirculation looks like in red color, whereas the venous color is the blood. Some of the circuit diagrams here, return cannula from the SVC, return cannula from the right atrium, and how it looks like. Certain circuit diagrams here for you to understand how it can be. And for recognizing the recirculation, if you look at the color of the tubes, drainage cannulae, you can see one of them dark and one of them red generally. But in case of recirculation, you will lose this color differentiation. It's the same bright red color blood circulating in both the return cannula as well as in the drainage cannula also. So there is no efficiency and tissues do not get oxygen. Okay. So that is how we recognize recirculation. The first noted indication of the recirculation is progressively decreasing pulse ox or peripheral oxygen saturation, usually below 86%. Second, often confirmatory sign of recirculation is increasing um, pre-oxygenation saturations. That is second sign that is noticed. With significant recirculation, higher pump speeds or flow often results in the more recirculation rather than improving it. So reduce the flow and see if it helps the situation. Again, one of the important factors for the recirculation is the tips of the cannulae. If the cannulae are very close at the kissing range to each other, Then blood will be pumped into the other cannula, venous cannula. So uh, we tend to keep at least 8 centimeters between the cannulae. So what causes recirculation? As I mentioned now, return cannula is no longer aimed at RA or tricuspid wall. Malposition of the cannula is very important. Excessive flow rates also for that particular patient, and abnormal pressure differences causing increased resistance within the right atrium that can cause my recirculation, also increasing recirculation. So what you do then, evaluate with chest x-ray if there is any or fluoroscopy if there is any movement of the tips of the cannulae, and then you can draw them apart so the recirculation fractures goes down. For two cannulae setups, increase the distance between the inflow and outflow cannula. Consider placement of a separate drainage cannula, allowing for a similar period of pump flow as a lower speed rates. So the weaning part is very briefly. Respiratory ECMO is mainly dependent on the um, on the gas supply. So you tend to wean by reducing the sweep flow before weaning saturations in adults. 3 to 5 or 5.5 liters per minute could be the weaning flow in adults. So before you match them, it is better to um, come down on the flow initially. That might help the situation. Decreasing the FiO2, decrease FiO2 by 5% every 1 to 2 hourly as the lungs get better. Then you can come off also. And the decreased sweep gas also. In veno arterial ECMO, you can adjust by reducing flow. Venous ECMO by reducing as per the sweep gas, venous support. Veno ECMO trial off and decannulation. When the blood gases are better, chest X-ray has improved, flow and FiO2 can be weaned further. Ventilatable patient is on the moderate ventilator settings, then that is the right time to think about the food at that time. Decannulation is a need for a second ECMO or re-ECMO. Sometimes, um, sometimes when the patient has achieved patient, ventilatable state, then also probably you should be able to come off ECMO, because if you continue an ECMO for a prolonged period of time, sepsis might set in also. So there are certain scenarios when if it is the right opportunity and right duration before the catches an infection, we can come off ECMO. So I'm not mentioning about the food or feeding in this part. That is a separate nutrition chapter. But nutrition is also very, very essential for patients on ECMO for uh, their ability to come off, for maintaining energy. So once you are satisfied, like the blood gases have improved, chest X-ray has improved, patients are able to ventilate themselves on moderate ventilator settings and maintain the gas exchange, that is the time to decannulate, that is remove the cannulae. In venous ECMO, cannulation, decannulation can be done by intensivists or any of the professionals also, because it is removal of the cannula and application of some pressure. Whereas in veno arterial ECMO repair, definitive surgical presence will be needed, because the blood is flowing at a high pressure in the arteries. So the arteries have to be either repaired or ligated. So surgical expertise is needed when you are trying to decannulate veno arterial ECMO, not venous ECMO. There may be a need for second ECMO or re-ECMO sometimes. We have seen that a minority of the patients, sort of 2% or 3% of our patients needed to go back onto ECMO after an initial period of improvement and then going down again. Follow-up is very essential. Uh, the period of ECMO, as it is like systemic inflammatory response during this period, multiple organs are involved. Our follow-up also should match looking after those organs in the period after discontinuing ECMO. Discontinuation from ECMO is not synonymous to discharge home. A quite significant proportion of patients drop off between this period even after decannulation of ECMO. So we should work very hard to equate these two numbers and not to lose patients after decannulation from the ECMO. That is ideal, but we are far off from achieving this ideal at this time. So, in the respiratory clinics, we need to do lung functions, treating infection related issues. Psychological problems may be there as well. They were alone for all this long. So, psychological factors also can be there. Post sedation withdrawal features, they need help in the follow up clinics. Cardiac evaluation, physiotherapy, rehabilitation, neurological evaluation, neurosurgical evaluation, um, and ENT for sensory neural hearing loss is needed because in 10% of the patients, hearing loss has been reported. So sensory, that to sensory neural hearing loss. So one has to follow up these issues. Quality of life issues also can be there. Prolonged period of ICU stay and post ICU stay may lead to problems with their jobs also. They might lose, some of them may lose jobs and need support also. This is one of the we know venous decannulations where we were simply pulling the cannula off and applying some pressure. So this is how a healed wound looks like on the neck after ECMO. How long will it take for recovery of the lungs is a very difficult question to answer. We wish this could be as minimal as possible, but there are times beyond our competence or our wishes. So those cases may need ECMO for more than 21 days or even longer also. In wealthy countries such as US, people think of paracorporeal devices for putting on as a wearable lung. We haven't reached that stage yet, but in principle, Bob Bartlett believes um, in respiratory ECMO. Once you continue as a single organ failure, even after a long period of time, such as an year or more, also they can bounce back and they can establish their own uh, lung function even after spending 1 year or more in ECMO. Maybe I'm going back with that, sorry. So these are examples of paracorporeal or wearable lungs for a child and adult. So they can wear their lungs till either their devices, sorry, till their lungs heal or take them through the lung transplantation route. Pediatric lung transplantation, um, the results in experience centers are better. There is a 5 year survival rate up to 25%, 35% survival rate there. It can fall down with time period, but generally at 5 years, it is 50% survival rate at 5 years post transplant. As the time goes by, then the rate will come down also. Pediatric lung transplantation, an overview of pediatric lung transplantation. In this article, the authors have mentioned 1 year survival rates close to 85% and 3 year survival rates moved to 65%. The problem here could be maintenance of the immune response and immunosuppression with artificially that will be needed post the transplantation period. In the adults also, similar sort of results. The transplantation registry data supported 1 year survival rate of 85% and 5-year survival rate of 59%. So ECMO is a mechanism used for prolonging the life but not death. Sometimes, unfortunately, if you come across a patient has ended up with non-treatable lung disease such as alveolar-capillary dysplasia or persistent protein deficiency or bronchopulmonary dysplasia, which is not amenable to treatment, or major intracerebral bleed. Those cases, one has to take decision about stopping the therapy if ECMO therapy by itself, such as continuing heparinization of the patient, is likely to harm the patients, then you have to take harder decisions of coming off ECMO and continuing on them on ventilation only. So the take home message is we have discussed indications and contraindications of ECMO, selection criteria, initiation and management of EV ECMO, recirculation and how to avoid recirculation, weaning and decannulation, prolonged ECMO, sometimes need for doing a re-ECMO, management strategies and further advances. Thank you very much for your patient listening. If there are any questions,